All right, well, welcome to this episode on medical terminology where I'm going to ensure that we all understand the medical term Odynophagia and use it appropriately as healthcare professionals. That includes knowing what it means, what causes Odynophagia, and lastly, common pitfalls to avoid in clinical practice. Hey guys, I'm Dr. Busti, and welcome to This Is Why, a show dedicated to helping healthcare professionals understand the why behind what we do and the words that we use every day in clinical practice. The medical term Odynophagia matters because people often confuse it with dysphagia. And if this symptom has an unclear etiology to you and unfortunately is ignored, you could be actually missing an underlying problem that could lead to a bad outcome for the patients that you're caring for. So first, let us define Odynophagia, which is basically pain with swallowing. That's it. Simple, specific, and clinically useful. Notice what it does not automatically mean. It does not automatically mean that the patient can't swallow, and it does not automatically mean that food is getting stuck. So that brings us to the most important distinction: Odynophagia versus dysphagia. Now, Odynophagia is swallowing pain or pain that occurs when the patient swallows. Dysphagia is difficulty with swallowing, like food getting stuck, choking, or coughing with liquids, or feeling like a food bolus just won't go down. Now, if you're not sure what dysphagia is and what causes it, see my lecture on that medical term. Okay, now it's relevant to note that patients can have one without the other, or they can have both. So get in that habit of asking your patients, is the swallowing painful, or is it difficult, or is it both? If you document it clearly, your assessment becomes sharper almost immediately. For example, here is how it's commonly used in some real examples and clinical notes. Quote, patient reports Odynophagia for 3 days. Okay, that's one. Odynophagia without dysphagia. Okay, again, very specific. Or Odynophagia with reflux symptoms. When you use the word, you're labeling a symptom. Your next job is to ask, why is the swallowing painful? Or what is causing this symptom? One way I do that is to organize the causes associated with higher anatomical areas in the mouth, okay, the oral pharynx and the throat, with lower areas in the esophagus. Let's take a moment and look at some of that and see some examples of common causes of Odynophagia. I'll say what you see is a cross-section or sagittal view of this patient with seeing the oral pharyngeal area in the upper portion of where the esophagus really starts. Okay, so you look through there, the mouth, and here we have the tongue, and then the soft palate where the uvula also hangs down. Okay, and then this is that posterior oral pharynx, and it's very close anatomy and proximity to the larynx that leads to the trachea, so that goes down our airway. We have an epiglottis that folds down as we swallow to protect that airway from food going directly into it right away. And then the esophagus, which passes behind that airway down into the thorax and eventually through the diaphragm, where it then will enter into the stomach. Okay, so if the pain feels high, like it's in the throat, okay, this oral pharyngeal area, you need to start thinking of common causes like a sore throat, viral pharyngitis, tonsillitis, or even strep throat. Let's look at some examples of those. Okay, in this particular image, you can see the posterior oral pharynx, very close. You can see the uvula here, okay, but you see in the tonsillar pillars back here basically exudate. Right? That's tonsillar exudates, consistent with a pattern, especially if patients have a fever, sore throat, no cough, right? Anterior chain cervical lymphadenopathy, that would be a classic pattern that would be consistent with strep pharyngitis, strep being a bacteria as the underlying cause, but that can lead to pain with swallowing. This is another example in a pediatric patient of herpangina. This is a common viral infection, okay, so different from strep, which is a bacteria, as I just mentioned. But you see these vesicles that get inflamed that form in the posterior aspect of the oral pharynx. Starts to almost look a little bit like thrush, esophageal candidiasis. But typically what you see are these vesicles. Again, it's very irritating, causes inflammation, discomfort with swallowing. And then lastly is the esophageal or oral pharyngeal ulcers that can start to form. You see a lot of erythema around this area. You can even see that the uvula looks a little thicker and more swollen. We sometimes call that uvulitis, okay? So those are common upper areas. If the pain feels lower, okay, behind the breastbone, or if the patient points to the middle part of their chest, you need to start thinking of the esophagus, okay? And specifically also the lower esophageal sphincter, which is at that junction where the esophagus enters and passes through the diaphragm into the stomach, okay? One of the most common causes and categories is esophagitis. That means inflammation of the esophagus, okay? And so reflux can do this. GERD can make that lining very irritated and swollen. So this is an example of the anatomy here, okay? This, what you see on the far left is really this green circular thing, which is a food bolus under peristaltic movements traveling down the esophagus through a period of contraction, relaxation, and as it enters and gets close to the lower esophageal sphincter, the lower esophageal sphincter is supposed to relax. That lets it open so the food bolus can pass by and now make it down into the stomach. Now, we swallow a lot of things, not just food, but also liquids. Liquids that can be hot, liquids that can be caustic. We can swallow pills, okay? And so there's something called pill-esophagitis that can occur, right? And this is, we see this a lot in our older patients. But pills can get stuck and stick to the tissue in that area and won't go down, right? And so if you have a patient scenario who took medications, they maybe go lay down, they didn't drink sufficient amount of water to move it all the way down into the stomach, and the patient now starts to experience sharp pain with swallowing, then you need to think about that. And again, our older geriatric patients who are on lots of medications, things like bisphosphonates in particular, can get stuck there and cause a lot of esophageal irritation and pain then when things go by. Now, there also things can get stuck at this level here. We can form strictures, rings from all that chronic inflammation. But patients can also develop what are called hiatal hernias, where a portion of the stomach literally comes up through the lower esophageal sphincter area and moves up in above the diaphragm. And there's different types of hernias based on the degree and severity of them. Sometimes they can slide up and down, all right? So depending on the imaging modality that you use to acquire the assessment of this and see this may influence whether you see it or not. The severity of being type 1 or type 2 versus type 3, you can clearly see up there as more problematic. So then things then have a hard time moving by. And then also what happens in these cases is that there's more acid moving up into that lower segment of the esophagus, causing that esophagitis, inflammation, irritation, and can even lead to conditions like Barrett's esophagus or esophagitis, okay? So anyway, those are the anatomy and points to think about and that associated with the underlying causes. Now, it's important to not forget that patients can also develop infectious esophagitis. This is especially going to be something of concern in immunocompromised patients. We need to think about things like Candida, HSV or herpes simplex virus, cytomegalovirus or CMV, and now even HPV, okay? Now, the teaching pearl here is severity. If an immunocompromised patient has marked painful swallowing, and even if it's sometimes minimal findings in the mouth, you still need to consider some type of esophageal infection, okay? Now, other causes to keep in mind include irritation after radiation or chemotherapy, ulcers in the esophagus, caustic injury after ingestion, like I mentioned before, and lastly, but sometimes even more importantly, is malignancy. Okay, again, remember that Barrett's esophagus can be precancerous and evolve to a cancer. This would be relevant, especially when you hear that the painful swallowing or swallowing with pain, you need to train yourself to think about some quick things, right? You want to think of throat infection or inflammation up top, reflux, pill injury, or infection down below. Always also pay attention to the story and risk factors. All right, so now let's consider 4 pitfalls that you want to avoid as clinicians. Number 1, treating Odynophagia like it's a diagnosis. Remember, it's a symptom. Your job is to find the underlying reason why that patient has pain. Number 2, mixing it up with dysphagia. Remember, it's pain versus difficulty that creates the diagnostic considerations that are going to be different between the two. Number 3, forgetting the medications and immunosuppression history. Those 2 pieces of information are disproportionately helpful. And then lastly, a quick clinical warning sign or mindset. If you see things like persistent symptoms, severe pain, dehydration from poor intake, or a concerning pattern like weight loss, progressive symptoms, or signs of GI bleeding, you should really raise the urgency for evaluation to occur sooner rather than later, and not just labeling this as a symptom. All right? So bottom line, Odynophagia is a medical term for painful swallowing. It's one of those words that makes your documentation and your differential diagnosis instantaneously more precise. I hope that this was helpful and interesting, but also relevant. I would really appreciate it if you haven't already to consider subscribing to our channel on YouTube, and also give us a like and share this with your friends, colleagues, maybe students, residents, depending on what you do, so we can continue to provide this information as well as many other topic areas for you. I'm Dr. Busti, and never stop learning the why, because that helps us master the how. Take care.